So let's see if I can get the slides up. First, I want to thank the ASAP organizers, as well as the co-hosts of the meeting this year, Dr. Heeger and Dr. Trumbull, for the opportunity to speak to all of you today. I really look forward to this conference every year. It's really unique. We go to a lot of conferences where a lot of researchers talk to other researchers, and this is really the only meeting, at least that I attend, where we can talk to, sure, researchers and physicians, but also patients, people who are suffering through these conditions. And certainly we learn a lot from the lectures, and the lectures I've already learned, I think, a lot today from Dr. Trumbull and Dr. Vez and their lectures, but I think I learned just as much from speaking to all of the patients that are here today too. So thank you to the ASAP and the organizers. I'm going to talk today about morphometrics, which sounds like perhaps a scary topic, but I think it's really very important and very relevant for Chiari. I have no conflicts of interest that are relevant to this talk. So what are morphometrics and why do they matter? Morphometrics is just a big word for measuring the body. So when we talk about head measurements, we talk about a morphometric measurement of the head. How long is a leg? How tall are you? How much do you weigh? These are all morphometrics. With Chiari, morphometrics matter a lot because the first thing that every patient talks about when they talk about their Chiari malformation is, well, how low are my tonsils? Well, my doctor said it was 8 millimeters, or my MRI report said it was 6 millimeters. And there's lots of other measurements now that are thrown out there too. You've heard today from our last two speakers about the SYRINX measurement. Is it 2 millimeters or is it 6 millimeters? These measurements matter a great deal. When we use imaging as part of the diagnosis, we're stuck talking about these measurements because it's how we communicate the imaging findings to one another, to doctors, to patients, and to researchers. There are obvious problems with these measurements, which you've already heard about today to some extent, and which I'll get into some more. Trouble is, right now, we don't have a great alternative because the diagnosis right now cannot be made 100% accurately on the basis of symptoms alone. We have trouble drawing that distinction between what is normal and what is abnormal on imaging scans. And part of the problem for that is we really don't have a great idea for what normal is, what's out there in the population, how abnormal is a finding. And then we'll talk about the 5 millimeter rule, which you just heard about from our last speaker. It obviously has a lot of flaws. It obviously isn't working, but nothing has really replaced it yet. So the 5 millimeter rule, that rule that says if your tonsils are 5 millimeters or more below the foramen magnum or the base of the skull, you have a Chiari. And if it's not that low, then you don't. That's an incredible oversimplification, right? But this is what a lot of people think. What are some exceptions to that? Well, you've heard of the Chiari 0 from our last speaker. Chiari 0 was a definition that came from the Alabama group about 20 years ago. That said certain people have symptoms and a SYRINX even though their tonsils aren't more than 5 millimeters below the foramen magnum, and that these people can get a Chiari operation and can improve with a Chiari operation and therefore should be treated similar to our classic Chiari 1 patients. Now, in the estimation of that group who made the definition, all of those patients had a large cervical SYRINX. So they certainly didn't want to introduce sort of a slippery slope definition that said the tonsil position doesn't matter at all. They said maybe it doesn't matter if you have a tight foramen magnum and you have a big cervical SYRINX. But it was a crack in the armor of that 5 millimeter rule, and that was a long time ago. Then we have asymptomatic Chiari 1s. You've heard from our speakers today, and we'll see a lot of other examples. People who have 15 millimeters of tonsils below the foramen magnum, 25 millimeters of tonsil below the foramen magnum with no symptoms. Right? Do they have Chiari? Well, it kind of depends who you ask and how they're defining Chiari. So 5 millimeter rule is I think, at best an easy marker for some other things that are more important, like how tight the foramen magnum is and how impaired the CSF flow is. But these are very difficult things to measure reliably, so instead we all fall back on this 5 millimeters. It's easy, convenient, and history is on the side of the 5 millimeter rule, unfortunately. This is how things used to be done many decades ago. We didn't have MRI scans. And this is a little bit hard to see. Do I have a pointer? You can see that arrow. So this is an X-ray with an air cisternogram, and this is the cerebellum up here, and this is the spine coming down here. And this arrow, which is on the screen, points to the cerebellar tonsil. And you can see that the cerebellar tonsil is coming down low into the spine. This is a difficult to do study, wasn't done very commonly. Showed a Chiari malformation. And in the old days, this is how it was diagnosed. And as you can imagine, Chiari wasn't diagnosed very often in those days. Starting in the early 1980s and picking up steam throughout that decade and then into the 90s, of course, there's MRI scanning. And now we're getting these pictures all the time. And does that rule make sense where we just say, well, low tonsils are all it takes? Well, there had to be some demarcation, some line in the sand that we could use to say this is a Chiari and this isn't. That's where 5 millimeters came from, but they're not all the same. You can see in this image on the left, this person has 5 millimeters of tonsil measurement, very pointed tonsils. This person in the middle, sort of intermediate, kind of a little bit round, not as pointed as the one on the left. And here's somebody with very round tonsils, lots of space, and yet is about 5 millimeters below the foramen magnum. So that measurement, that morphometric measurement, certainly doesn't tell the whole picture for that patient. So where did this number come from? The major bit of research that led to the adoption of the 5 millimeter rule came from 1986. Now again, this is at the dawn of the MRI era. MRIs had been around for a few years, and now people are showing up to their doctor's offices with these pictures, and doctors don't know what to make of it. So this group in San Francisco decided that they would look at their Chiari patients and they would compare them to patients that didn't have Chiari, and they would measure all their tonsils. And that's what they did. They had 25 Chiari patients, which in 1986 was considered a decent series, and 200 patients that were pre-selected for being normal, that is to say not having Chiari, and they just compared these two groups. And then they picked different cut points. They said, what if we say we're going to just use the foramen magnum as the cut point? How many of the Chiari patients have tonsils below that, and how many normal patients have tonsils below that? Or what about 1 millimeter below? Or what about 2 millimeters below? And on and on and on they went till they got to 5 millimeters. And you can see at the bottom there, at 5 millimeters, according to this group, in 1986, based on 25 patients, the 5 millimeter rule had 92% sensitivity and 100% specificity. That is to say, they thought that there were essentially no asymptomatic patients more than 5 millimeters. And that's nonsense. And I think every neurosurgeon that sees Chiari patients knows that's utter nonsense. But it's the best they could do in 1986. I think it was a nice study for that time. The problem with that is that there are, as you've heard today from the other speakers, lots of asymptomatic individuals that meet that diagnostic criterion of having tonsils 5 millimeters below the foramen magnum. We looked at about 85,000 consecutive scans at our institution and found that about 1% of those individuals getting scanned at our institution met that definition of Chiari, and that fit with some findings from some earlier smaller studies. Again, 1% is kind of the easy take-home number. 1% of the U.S. population has tonsils below the foramen magnum by about 5 millimeters. It's not as simple as just understanding that there's two groups in the population, those with quote-unquote normal tonsils above that measurement and a group with abnormal tonsils below that. These are not two groups. This is a normal distribution in the population, a bell-shaped curve in the population where most people, this is our data from Journal of Neurosurgery a few years ago, this is numbers of people here, so the taller bars is more people, the smaller bars are fewer people. This is the foramen magnum here in the middle. People are bunched at the foramen magnum if you measure their tonsils, and the farther you get from the foramen magnum, either higher or lower, the less and less common that becomes. And people with the 5 millimeters or more below the foramen magnum are outliers off of a bell curve. This is not a completely different population of people. These are outliers in the normal population, which I think is an important distinction to make. Those are our findings. The graph on the right is from another paper published by Sun and others in Spine, which essentially found the same thing. Age matters a lot. So we talked about how 1% of the population has tonsils more than 5 millimeters below the foramen magnum. But that's not true if we're talking about young people, and it's not true if we're talking about very old people, because this changes throughout life. Here are our data from 2013, and this graph essentially shows tonsil position over the course of life. The x-axis there is age, broken down by decades, 0 to 10, 11 to 20, and so on. And we measured, again, this is in that 75,000 group. We measured tonsil position by decade, and you can see that in general it starts out a little bit above the foramen magnum. In the 21 to 30 age group, that's when tonsils on average are the lowest, and on average it's around the foramen magnum then. And then it does tend to ascend throughout life. Dr. Vez made the comment earlier that even elderly people can get Chiari malformation. I certainly agree that that's true. However, I do think it's less common than in the teenage age groups and in the young adult age groups, where we see most of our symptomatic Chiari individuals. And I think that's reflected here essentially in this graph. Why are most people presenting with Chiari symptoms in the teenage years and the young adult years? Well, that on average is when your tonsils are the lowest. That doesn't mean babies can't have symptomatic Chiari. It doesn't mean elderly people can't have symptomatic Chiari, but we're just talking about trends and propensities. When you talk about the prevalence of Chiari, there was a Hopkins paper from about 20 years ago now that said it was about 1% in their group of mostly adults. And again, I agree with that when you look at the population as a whole. When you look at the pediatric population, though, it's even more common than 1%. Why is that? Well, because you're selecting out a group of people that have lower tonsils. So if you're talking about teenagers, young adults, it's more like 2%. If you're talking about everybody all taken together, sure, 1% is a reasonable number. Again, every decade you look at, you're going to have a normal distribution with Chiari patients or patients getting diagnosed with Chiari at one end of that normal distribution, but the distribution changes by age decade. So looking at it another way, here's just a perfectly normal patient with the foramen magnum, and there's the normal bell curve by decade kind of shown there at the foramen magnum, and you can see where are the Chiari patients? Well, they're the ones that are going to be at the low end of that distribution, the red bars on that graph. So that's the 5 millimeter rule. A lot of problems with that, obviously. What about symptomatic Chiari, though? You might say, well, you're just talking about MRI findings. You're not talking about people who are suffering from Chiari. So how common is that? Well, that's less common. The best study to date on that is this Kaiser study from California, where they looked at about 750,000 patients insured by a single insurance plan, so they could find out exactly who was getting MRIs and who was getting diagnosed and who was getting surgery and so on. And in that group, they had about 5,000 patients that had an MRI over the course of 2 years, and 32 symptomatic patients with Chiari on imaging in that time period. So the 2-year period prevalence was 0.7 per 10,000. So that's about 2 orders of magnitude different than the MRI prevalence would be expected to be in that population. So the diagnosis is much more common than the surgery. So again, symptomatic Chiari is relatively rare. Dr. Heiss is here in the back row at the NIH, and this is the NIH website, the Office of Rare Disease Research, where you find Chiari malformation. There's a little red asterisk there on the left side of the screen where Chiari malformation, and that's actually on the NIH website, at least it used to be, and it says not a rare disease. So Chiari, supported by the Office of Rare Disease Research, on some level has been considered a rare disease, but now everybody coming around to the idea that, depending on your definition, really not a rare disease at all. So what's the natural history for all of these individuals that are out there with an imaging finding of a Chiari, but who feel perfectly well? Well, the good news is the natural history appears to be very good. This was the first natural history paper from Italy about 15 years ago, and they had 22 patients that they followed, and most did well over a long-term follow-up. A larger study from Miami, 124 patients over 9 years. And again, the vast majority of these patients did well long-term with no treatment. Here's our own study from a few years ago, 150 patients, 5-year follow-up. 16 of those patients ended up needing a Chiari decompression, 16 out of 148 over 5 years. So the vast majority do well with no treatment and remain asymptomatic. I will say that in many of those cases, these were not 16 patients that went from completely asymptomatic to having terrible symptoms and needing surgery. In many cases, they had some mild symptoms, weren't really convinced that they were a surgical candidate, and symptoms either failed to get better for a long time or got worse, and then they had surgery. So in many cases, these were not symptoms out of the blue. Natural history of tonsil position also is another bell curve. When you follow these patients over time and you say, are you going to look worse or are you going to look better on your MRI in 5 years? The answer is, well, in any individual case, we have no idea because anything's possible. But on average, people stay about the same, but they can get a little better or a little worse. And the more better and the more worse they get, the less and less likely that becomes, the more of an outlier they are. I don't think I have a slide for SYRINX change over time, but I could show you essentially the same data for that. Dr. Vez, I think, showed the slide earlier. A patient with a large SYRINX that he had recommended surgery for that didn't want to have surgery, and then has been doing well over time. And we've seen somewhat of the same phenomenon. We've had several patients now with SYRINXs that are probably surgical candidates that didn't have surgery, and the SYRINX just resolved over time. And certainly we see a lot of patients with no SYRINX that develop SYRINX, or small SYRINXs that get bigger SYRINXs. So I think anything is possible with respect to that. So again, the big question, how do we define disease? These are two different patients. The patient on the left, I think, has a much more severe Chiari, at least on the basis of imaging, has wedge tonsils, has a big cervical syrinx. If this patient is completely asymptomatic, are we going to call that patient diseased? I think most people would, but I think it's also a debatable question. Patient on the right, not very impressive imaging, has some tonsil ectopia for sure, down to the level of C1. This patient has bad symptoms. Are they diseased? Well, I think most people would say yes, but I think it's, again, worth some debate. Really what it comes down to is, are we using clinical criteria or imaging criteria or both? And I'll argue that we really need to use both. Imaging criteria by itself is definitely not the answer at the moment. That puts us in a little bit of a precarious position, especially in America. This graph is from the Journal of the American Medical Association. And basically what it shows is these lines are individual regions of the country and how many MRI scans are being ordered in these regions of the country. And the individual numbers don't matter, but this is over a decade, and you can see that the numbers are just going up and up and up. No matter where you are in this country, we're getting more and more MRIs. The United States is an outlier in the world, even compared to developed countries, with respect to the number of MRI scans that are being ordered in the United States. This is OECD data, the Organization for Economic Cooperation and Development out of Geneva, associated with the United Nations. And they look at lots of health metrics, infant mortality and so on. But here's MRI utilization per unit population. And you can see the United States on the top bar, 91 per thousand population. The average of developed countries is 41, so we're over twice the average. Canada is in the middle there at 31. So if you live in the United States, you're 3 times as likely to have an MRI as if you live north of the border. So we do have a lot of MRI scans getting done in this country. Is that a good thing or a bad thing? I think that's debatable. It certainly does lead to a lot of helpful diagnoses, that's for sure. But we do have to be prepared for the information that we're getting, and we need to be able to interpret the information we're getting. And I think in many cases, our ability to scan people has got ahead of our ability to actually know what to do with that information. Here's new Chiari diagnosis. This is from one of our papers from Journal of Neurosurgery 2 years ago. Looking at another privately insured database. This one has 30 million people in it. though, so I think the data is relatively meaningful. And again, the exact numbers don't matter, but the point is, over a 15-year interval in this population in the United States of 30 million people, we're diagnosing about 2.5 times as many Chiari patients annually now as we were 15 years ago. So the rate of Chiari diagnosis is going up and up and up and up, and I would argue that to some extent this parallels our MRI utilization in this country. I think it's no surprise. So we definitely need better metrics. We need to know what to do with this information. We get a scan, it shows 5 millimeters. What does this mean? Do we recommend surgery, or are we going to help somebody with this surgery? Is this even a Chiari? Everybody pokes holes at the 5 millimeter rule. The trouble is, what are we replacing it with? Are we saying, well, it's an entirely clinical diagnosis? Well, I've got the big Lebowski here. His famous quote was, every time somebody criticizes him or says something he disagrees with, he just says, well, like, that's just your opinion, man. And I think there's a real danger with that when we're talking about brain surgery, that we're just saying this diagnosis is like your opinion, man. We need something we can hang our hat on, some number. We just don't have a really good one yet. The number needs to be meaningful, and it needs to correlate with symptoms. It needs to correlate with dis-ease, with feeling bad. All right? If our number doesn't have any correlation with that, then it's probably not very useful. It needs to be measurable, again, to get rid of this Lebowski effect, where we're all going to have a disagreement about what we're even looking at, and reliable between raters. So people have tried lots of things. Here's one of our studies, which I'm not going to talk about in any detail, but we said, okay, 5 millimeters is terrible. What are we going to do? And we measured 100 different other parts of the head, and we said, okay, is this going to differentiate Chiari patients from other patients? And we put it through a computer, and the good news is we came up with a formula, and it says we're going to 100% predict who has a symptomatic Chiari and who doesn't. And then we tried it out in a brand new group of patients that weren't used to actually get the data, and it was completely ineffective. It was a complete waste of time. So far, that's been the problem. Pointed tonsils, can we do that? Yeah, I think pointed tonsils is a really useful marker, but on the other hand, it's not as measurable. Deformation, again, I think that's really useful. I look at that, but it's not as measurable. CSF flow impairment, that's a whole nother hour talk. I do think that a lot of the symptoms are due to CSF flow impairment. I do think it's really important from a pathophysiological standpoint. The problem is we can't reliably measure it, not between institutions and between raters, and lots of groups have now shown that even the same patient on the same day getting 2 different scans will have 2 different measurements. It's just not reliable right now. Furthermore, if we know what the morphological state of the MRI is, and we know what the patient's symptoms are, does knowing that number, as unreliable as it is, ever offer us information that pushes us one way or the other in terms of getting surgery or not getting surgery? And at least at our place, the answer seems to be no. So we've actually stopped recommending them, although our radiologists usually get them anyway, whether we ask for them or not. This was a article that came out earlier this year in Journal of Neurosurgery, where again, we looked at the same sort of thing as Chiari and not Chiari that I told you about, but this time it actually worked in the sense that we couldn't see any difference between patients with a Chiari who had symptoms and patients with a Chiari who didn't have symptoms. And we looked at it 100 different ways. Here's some of the ones here you can see illustrated, all of these measurements. We thought, is there going to be some difference? All of these patients are going to get matched for tonsil position, because we already know that about them. So we know we have a 15-year-old with 8 millimeters tonsils below the foramen magnum, and they have terrible Chiari symptoms. And then we match them up with a 15-year-old with 8 millimeters below the tonsils, below the foramen magnum, who had 0 symptoms whatsoever. And we said, okay, what's the difference here? Can we find any measurement that's going to be responsible for this difference? Here's our data. You don't have to look at this if you don't want to. The bottom line is the answer is no. No matter what we measured, we couldn't find anything that would reliably predict symptoms or no symptoms in patients who are otherwise the same with respect to their tonsil morphology. So then we tried volume. We said, okay, maybe two-dimensional measurements are too simple. Maybe it's not really painting the picture accurately, and this is a three-dimensional space after all, and we have three-dimensional CSF spaces. So now we need to measure three-dimensionally. So we use this volumetric program to look at posterior fossa volumes and compare it, again, all Chiari patients, but some with terrible symptoms and some with no symptoms. And is there a difference in terms of posterior fossa volume there? And the answer was no. And then, well, what about just the bottom part of the posterior fossa, the caudal posterior fossa volume? Is there a difference there? And the answer is no. Or what about the top part? No. No matter what we looked at, the answer is no. So right now, much to my frustration, I'm not satisfied that we have another reliable marker for differentiating symptomatic from asymptomatic individuals with Chiari. And you might say, well, just if they have symptoms, they're symptomatic. And as I think most of you know, it's not that simple sometimes, because some symptoms are relatively nonspecific, and it's very difficult to tease out if the symptoms that this patient is suffering from is from this MRI finding. Is there a cause and effect relationship, or are they just both together in an association that's not causative? So let's talk about SYRINX briefly. You heard a little bit about it today. I do, for the most part, consider a large cervical SYRINX a reason for recommending surgery in most cases. So this is an example. This patient has a Chiari that I think is impressive on MRI, has a SYRINX, if I can get the marker, this cavitation of the spinal cord going very high. And that would be a surgical patient in my clinic. Same thing here, another patient, Chiari, pointed tonsils, big cervical SYRINX going down into the thoracic spine. Again, this is somebody who would get a surgical recommendation from me. What about this person? This person you heard about from Dr. Trumbull, you heard about is it 2 millimeters, is it 3 millimeters as a definition for SYRINX? Most researchers use 3 millimeters as a definition for SYRINX. So here's somebody with a thoracic SYRINX. It's definitely more than 3 millimeters wide, but it's in the thoracic spine. It's not as wide as the two examples that I showed you at the left. Does that person get surgery? What about this? Here's an even thinner one. This is sort of that central canal that Dr. Trumbull was talking about. Does that person get surgery? Well, I'm going to argue no. I don't recommend surgery for otherwise asymptomatic patients with those SYRINXs, and here's why. This is a paper that we published in Journal of Neurosurgery a few years ago, and it looks at all of our SYRINX patients, people who have SYRINXs for any reason whatsoever. So some of them had Chiari, which is this first bar here. Some of them, this is Chiari 0, this is secondary Chiari, so you can kind of treat all of these together as a Chiari type phenomenon. And here's idiopathic SYRINX, here's tethered cord SYRINX, and so on. And the point is, there's a difference when we look at SYRINX width. In general, there's overlap, but in general, the people who are identifying as Chiari SYRINX had wide SYRINXs, right? The idiopathic and tethered cord SYRINXs tended to be skinnier. The location differed as well, in general. The Chiari SYRINXs, who again are now at the top of the screen, here's Chiari 1, Chiari 0, secondary Chiari, so again, you can kind of lump them together. And then this is levels from the foramen magnum. So if you look at the gray bars, which is where the SYRINXs start, the cranial or top extent of the SYRINX, they tend to be up near the foramen magnum, or in other words, in the cervical spine. If you look at idiopathic syringes, the tethered cord syringes, they tend to be lower. Okay, so again, Chiari higher, idiopathic tethered cord syringes lower. So now put both of those pieces of information together, the SYRINX width and the SYRINX location, put them together. And here's the Chiari population. Here's people who have Chiari, and you can see that there are outliers, right? There are people who have Chiari that have these thin thoracic things as well, obviously. But for the most part, the Chiari patients are bunched up there all together, all grouped with the wide SYRINXs up close to the foramen magnum in the cervical spine. At least how I've used these data is when I'm recommending surgery on the basis of a SYRINX in a minimally symptomatic patient, I want to see that there's a cause and effect relationship. I want to believe that the Chiari is causing the SYRINX, and I think that the strongest case to be made for that is a syrinx in the cervical spine that's big. For that reason, if the only indication for surgery is a thin or thoracic syrinx, it's not enough of an indication for me in my practice, just my opinion. Maybe there's a cause and effect relationship there, but we can't prove it. I certainly can't prove it, and I'm not going to put somebody through brain surgery for that reason. So, syrinx with Chiari, for sure. I think there's a strong association between Chiari and these syrinxes. I think there's a weak or no association between syrinx and Chiari in these cases. If these two patients on the right had a Chiari malformation and were otherwise asymptomatic, they would not get surgery from me. So is it associated with syrinx? Yes, of course it is, but there are important exceptions. Not all Chiari patients have a syrinx. Not all syrinx patients have a Chiari, and this is the most important part, I think, not all patients with Chiari and syrinx have a syrinx that's caused by the Chiari malformation, right? There was a paper published about 20 years ago that said, always get a total spine MRI on all your Chiari patients, because if you don't, you're going to miss 10 or 15% of the syrinxes. And I think that paper was absolutely correct. You do miss some syrinxes if you don't image the whole spine. The question is, am I actually going to do anything differently if I find a thin thoracic syrinx? And the answer is no. So I always get total spine MRIs anyway. But frankly, it's been a long time since I feel like any information that I get on a thoracic or lumbar image has changed my mind about anything. So ventral morphometrics, what I mean there is ventral pathology, or things that are in front of, we think of Chiari as being a compression behind the foramen magnum, at the back of the foramen magnum. The cerebellum is in the back. And when we talk about ventral, we talk about the retroflexion of the dens, things pushing into the spine and brainstem from the front. Here's somebody that I found this picture actually off the internet. They believe they had a retroflex dens. I disagree. This is a study that we just recently completed and has not been published yet. But when we talk about ventral pathology, we're really interested in a couple of measurements. The most frequently used one from surgeons' standpoints is the PBC2 line, or also called the Grab-Oakes line. And that essentially is a measurement from the dens to the neural structures and saying how much is it getting compressed from the front. And Grab and Oakes, about 25, 30 years ago, said that if it was more than about 9 millimeters, that was a sign that things were getting pushed from the front, and that maybe a decompression from the back wouldn't be enough in those cases. And you might have to consider either a ventral decompression or a fusion. In recent years, there's been some pushback on that, saying maybe it's not 9, maybe it's 8, or maybe it's 7, and that number is kind of getting lower. So how could that be? What's even normal for a PBC2? We didn't really know. So I decided to study that. This is in 25,000 consecutive patients having CAT scans at our institution, measuring, well, lots of things, but this graph shows the PBC2 line. And this is age here at the bottom of the screen, so 1-year-olds to the left and 17-year-olds at the right. And you can see, obviously, the measurement is normally low in young children, but by the end of the first decade of life, it arrives at its sort of stable position, which is on average just shy of 6 millimeters. But one standard deviation, which is very common, gets you up to about 7 millimeters. So that, again, I don't think we should be using 7 millimeters as a criterion for doing a very, in my opinion, morbid operation on people when it's actually a very common normal finding in the population. Here's the same graph with the Grab-Oakes people. That's Jerry Oakes on the left and Paul Grab on the right. And there's the line at 9 millimeters. And they identified at 9 millimeters as being a sign of real ventral pathology. And for me, I think the data I'm showing you here really reinforced that. I'm certainly not interested in putting people through ventral decompressions or fusions for anything less than that. the dens angulation in the normal population. I think there's a lot of confusion out there about dens angulation in the sense that the dens is normally retroflexed a little bit. So when you talk about, is my dens retroflexed, well, what you mean is it pathologically retroflexed? Is it more retroflexed than it should be? Because most people, as I'm showing here, have a retroflexed dens. This is the same study, again, not published yet. Age 1 on the left, age 17 on the right. And these are degrees here on the y-axis. 90 degrees is at the top, and that's a straight up and down dens. Everything short of that is a start of a retroflexion, right? So even in babies, there's a little bit of retroflexion around 80, and actually our study only went up to 17 years of age. I'd be interested in doing the same thing in adults, but 70 degrees is very common and is average. So everybody, or at least most people, have a retroflex dens. The question is, how much is it retroflexed? And it needs to be quite retroflexed before I recommend anything different than a standard posterior decompression. So I'll conclude with just a few thoughts. The 5 millimeter rule for tonsil position is seriously flawed. There's nothing magical about 5 millimeters, right? It's just a cut point that we've relatively, I would argue, arbitrarily picked off of this normal distribution curve. There are no definite pathological implications. There's nothing definitely wrong with you if you have 5 millimeters. It wouldn't be wrong with you if you had 4.5. It does put you at risk for a certain set of problems, right, which we identify as the Chiari syndrome. And I didn't show you these data, but certainly I believe it's true that the lower your tonsils are, the more likely you are to have symptoms. It doesn't mean that you can't have very bad symptoms with relatively higher tonsils. There are lots of outliers, but you are more and more and more likely to have symptoms the lower and lower and lower tonsils the tonsils are, just on a population basis. Symptomatic Chiari, as I showed, is relatively rare, but asymptomatic low tonsil position on imaging is very common. The natural history, or what happens if we do nothing for asymptomatic or minimally symptomatic individuals, is very good in most cases. So Dr. Vez gave some opinions, some surgical opinions. I'll share some of mine. Again, these are just my opinions. This isn't science anymore. This is just what I use as a basis for surgery. In general, most of my surgical patients have tonsils below the foramen magnum by 5 millimeters. That's not 100% true, but it is in general true. I do like to see not just that, though. I want to see evidence of tonsillar deformation on the MRI, evidence of crowding at the craniovertebral junction, and either very consistent symptoms or a large cervical syrinx. Imaging diagnosis of ventral compression is very, very poorly defined. Every surgeon has a different criterion for deciding when they're going to do a ventral decompression, and I think I try to set the bar very, very high for that, and in general favor doing standard posterior decompressions, really regardless of PBC2 or dens angle, unless it's really bad. So I've just got to, do I have time? Do I have a few minutes? Oh, really? Okay. Well, 1 minute. Just listening to some of the speakers this morning talk about some other issues. I just thought, again, I'd give some of my opinions. With respect to restrictions, I do not restrict any Chiari patients. If you're asymptomatic or minimally symptomatic, i.e. not a surgical candidate, there are no restrictions whatsoever. I'll let those patients play football or do anything they want. If you're a surgical candidate, I don't let you participate in sports for 3 months after surgery. And then if things are healing the way I expect, then you get the all clear to participate again in essentially anything you want. We've got quite a lot of data now, thousands of sports participation seasons in the Chiari population, and so far we haven't seen any serious problems in our population. There will be problems because there are problems with everybody participating in sports, but the question isn't can there be a problem in a Chiari patient? The question is that happening at a rate that is sufficiently higher than the normal population to warrant severe restrictions? In my opinion, the answer to that is no. Genetics, interesting question. I agree with Dr. Trumbull's statement. I don't think we're going to find a Chiari gene. The distribution of tonsils in the population doesn't fit with a single gene disease. I think that's just impossible to believe. There might be 100 Chiari genes, that I believe, but I don't think we're going to find one. I think you might find one in one particular family, but there's going to be 99 others as well. So far, I'm not really sure if that's going to be very helpful in terms of finding a treatment or cure for this problem. IMRI came up. I used to use the intraoperative MRI scanner for my Chiari operations. I had a bone-only phase where I didn't open the dura in selected patients about 5 years ago. And frankly, I was disappointed with bone-only decompressions and have completely given them up. So when I used the intraoperative MRI scanner, it was to see how well we had done with the bone-only decompression and assess whether or not we needed to open the dura. I got to the point where the answer was always yes, I need to open the dura. So now I don't do the intraoperative MRI scans anymore. And with respect to post-op imaging, I get scans at 3 months and a year post-op. If that 1 year scan looks good, I dismiss patients from care at that point. I don't think you need lifelong follow-up if you've had a good result. So thank you very much.